Hello, everyone. I'm Jana Fehr. I'm a PhD student in machine learning and digital health, and I'm co-supervised by Emily Wong at the Africa Health Research Institute and Christoph Lippert at the HPI in Germany. And today I'm happy to share our experience of using CAD4TB in a prospective health screening program in rural South Africa. Just to give you a bit of a background, so in South Africa, TB is still one of the most important health problems and also one of the leading causes of death. And it often also co-occurs with a high rate of HIV infection. And one problem to control the TB infection is that often people with TB seek healthcare only quite late, because sometimes the access to healthcare can be difficult, especially in rural areas. Last year, there was also a completed national TB prevalence survey, and there they estimated that there are many people with undiagnosed TB living in South Africa. And the study that I am presenting you today was conducted in a rural area in northern Kwazulu Natal, indicated by the circle here. The health screening program was called Vukuzazi, and it was a very ambitious study by the Africa Health Research Institute, and they aimed to understand the complex health problems that exist in this community. And they invited local residents for a free health screening checkup at a mobile health camp that traveled around within 1 kilometer of each person's home. And the study characterized the infectious but also the non-communicable disease burden in this community. But in this talk now, I will only focus on the TB component in this study. But of course, if you want to find more information, there will also be a paper coming out this month. It appears in the Lancet Global Health. Feel free to check it out. So for this TB screening, the participants were asked if they experience any current symptoms such as fever, cough, night sweats, or weight loss. And they also underwent digital chest X-ray imaging in a van that was equipped with a mobile chest X-ray unit. And then following WHO guidelines for TB prevalence surveys, participants received sputum testing if they had an abnormal chest X-ray or if they experienced any current symptoms. And among those participants who were triaged for sputum testing, microbiological sputum testing was performed using Expert Ultra and MJIT liquid culture. And also as a backup, the study team decided to use CAD4TB to triage chest X-ray in real time in the camp as being abnormal normal. But then also at a later date, there was a senior radiologist who read each of these chest X-rays independently, blinded to what CAD4TB said, also blinded to symptoms and other patient data. And this radiologist indicated whether the chest X-ray was normal or abnormal, and also judged whether the abnormalities were due to active TB or not. When the studies rolled out in 2018, there were already several reports about CAD4TB that said that CAD4TB had a really good triaging performance in clinical settings using CAD4TB scores 60 and 65, but it wasn't very clear to the study team if these thresholds 60 to 65 would also be applicable in this prospective community-based screening program, and therefore the team conducted a pilot study that consisted of the first 1,132 study participants. And in this pilot, the participants were triaged for sputum testing when they were at the mobile camp if they had a CAD4TB version 5 score above 60. And then later on, the senior radiologist who was doing like the central reading, if the radiologist indicated abnormal lung fields for a participant who was not triaged in the camp, then there was a follow-up team who visited the participant at home and asked them to submit a sputum sample. And at the end of the pilot, they compared the CAD scores to what the radiologist indicated as normal or abnormal chest X-ray. And as you can see here on this chart, was that there were many chest X-rays that had a CAD4TB version 5 score below 60 that were rated as abnormal by the senior radiologist. Also, there was not really a single threshold that could potentially identify all the abnormal chest X-rays with perfect sensitivity. And therefore, the study team decided that for the remainder of the study, they would continue using a threshold at 25 because this maximized the number of abnormal lung fields that were identified in the field. And that was also like, yeah, without overwhelming the laboratories with too many sputum samples. At the end of the study, we analyzed the data after the first year of the Vukozazi program was completed, and in total there were 9,914 participants who underwent chest X-ray, chest radiography, and 30% of these participants were found HIV positive, but most of them had full viral suppression and were on antiretroviral therapy. In total, there were 99 participants, which was like 1% of the study population, who had definite TB, which we defined as microbiologically confirmed by either expert ultra and TB culture or both of these tests. What was very interesting was that 80% of these participants with definite TB did actually not report any TB symptoms. There was also another group that we called probable TB. This comprised 1.7% of participants, and with probable TB, we defined that as having radiological diagnosis of TB. So the senior radiologist indicated diagnostic signs of TB on the chest X-rays, but there was no microbiological confirmation for this. Yeah, more results you can also find in the paper that will appear next month in Nature Partner Journals Digital Medicine, and you can also find it on medRxiv. In our study, we found that definite TB comprised actually a spectrum of lung field abnormalities. So here you can see the chest X-rays of 2 participants with microbiologically confirmed TB. In the top row, this participant had significant consolidation in the upper lobe and also a very high CAD score at 95. And in the bottom row, you see that there's not very clear abnormality, which is also reflected by the relatively low score of 39. And in general, we found that the scores of participants in this definite TB group had a very wide range from 19 to 100. And what was also interesting for us to see was that the scores in the group of probable TB, they tended to be higher than actually the ones in the definite TB group who had microbiological confirmation. We also checked whether the HIV status of the participants could have an influence on the scores, but we couldn't really find significant differences between these groups. We also assessed the performance of CAD4TB version 5 to identify definite and probable TB. And we found that CAD4TB version 5 had excellent performance to identify probable TB here marked in this light blue curve. But the ability to identify definite TB was lower. And we also compared like how many definite TB cases the radiologist would have captured by indicating lung field abnormality, and that was at a sensitivity of 80.8% and a specificity of 66.9%. We picked the CAD4TB version 5 scores that matched this radiologist's sensitivity the closest, and that was for us the scores around 39 to 40. But however, for these scores, we could see that the specificity was lower compared to the radiologist. And also here we compared also the curve, if there was a significant difference between HIV positive and negative individuals, but couldn't find any significance. After the study, the first year of the study completed, CAD4TB version 6 became available, and Delft recalculated the CAD scores with this new version, and we performed the analysis again with the new version. And this time we found that CAD4TB version 6 scores of 47 to 48 had the closest match to the radiologist's sensitivity. But at this time, the specificity was higher compared to version 5 and very, very close, like more or less the same to the radiologist. However, there was not no CAD4TB version 6 score that could really outperform the radiologist in both like sensitivity and specificity. And also here again, we did not find any significant differences between people with and without HIV. Yeah, at the end of the day, finding an optimal triaging threshold means that you have to balance the costs that are required for sputum testing with the number of TB cases that you want to find, or that would be missed if the threshold is too high, for example. And on this left graph here, you can see the percentage of participants who would require sputum testing, and our chosen threshold at 25, here marked by this gray horizontal line, would have tested tested 60% of the participants, so really the vast majority. And of course, this had cost implications, and this was also 3 times higher compared to who the radiologist would have sent for sputum testing, which is marked here by this dashed horizontal line. And on the right, you can see that using a CAD4TB threshold at 60 that was reported from other studies would have missed 44% of the definite TB cases that we found in our study. But using our low threshold, we could also identify 19 additional cases compared that the radiologist would have missed. So in conclusion, I hope I could convince you now that CAD4TB is an applicable tool for community-based screening programs. Especially, it was nice to see that CAD4TB version 6 can really reach a similar performance to a senior radiologist. However, we see that there is this important challenge for prospective screening programs, especially to find an ideal triaging threshold that really balances the number of costs for the sputum test with the number of missed TB cases. And we found that triaging thresholds from other studies were not applicable in our settings and would have missed like nearly half of the TB cases that we found. And we think that piloting is a very important approach for prospective programs. And yeah, of course, there is an ongoing discussion about which factors might affect CAD4TB scores and therefore the triaging threshold selection. At least in our study, we did not find evidence that the high rate of HIV co-infection influenced the scores. One important lesson to note is that because we used this low triaging threshold at 25, we were able to see that active TB can also be quite radiologically subtle, which we hypothesized that this can be a rather subclinical phenotype. And in order to close this large gap of underdiagnosis of TB, it would be really interesting to see if CAD4TB, for example, could also be refined to identify the subclinical and subtle phenotype of TB. And yeah, with this, I would like to thank the team at the African Health Research Institute, especially Emily Wong, my supervisor, also the community to give the trust and to participate in the study, and also my supervisors at the HPI and Frank and Rick for collaborating with us. Thank you very much.